Assalamu alaikum. Today I would like to discuss on Legg Calve Perthe disease. Legg Calve Perthe disease. Okay, start with this stem. If you read this stem, like this 6-year-old boy brought to the office, why? Due to limp. Our symptom began 2 months ago with a dull ache, left knee pain. There is a dull ache, left knee pain with an intermittent limp. The patient is brought to the urgent care, mm, and X-ray and hip are normal. X-rays of the knee and hip are normal. The pain has not worsened, but the patient now persistent limp. he has he has been well except for a brief upper respiratory infection with a low-grade fever about 2 weeks. He has a history of recurrent infection. He has a history of recurrent infection and head tympanostomy 2 years ago. The main concern in here examination shows a well-appearing child, range of motion, particularly internal rotation and abduction. Range of motion, particularly internal rotation and abduction of the left hip is markedly limited. So internal rotation and internal rotation and abduction of the left hip is markedly limited. The remainder is normal. Which of the following is the most likely diagnosis? Okay, probably it is Legg Calve Perthe disease. I have to differentiate between these three. These three is just closer to one after another. Okay, in Legg Calve Perthe disease, if you look at it's a idiopathic avascular necrosis of the femoral head. A boy age 3 to 12. This boy is 6 years old. Boy age 3 to 12. Insidious hip pain and limb. Hip pain and limb. There is restricted hip abduction and internal rotation. There is hip restricted hip abduction, restricted hip abduction, and internal rotation. There is restricted hip abduction and internal rotation. There is positive Trendelenburg sign. This is another high-yield talk that Trendelenburg positive Trendelenburg sign. In X-ray, there is early changes, maybe normal. In later stage, there may be femoral head flattening, fragmentation, sclerosis. MRI of the MRI shows avascular or necrotic femoral head. MRI shows avascular or necrotic femoral head. Treatment is non-weight bearing and splinting. So this patient likely has Legg Calve Perthe is idiopathic necrosis of the femoral head. Classically, FX boy age 3 to 12. Peak incidence is age 6. Patients have an antalgic gait, a dull chronic lower extremity pain. Chronic lower extremity pain is insidious onset. Diagnosis require high index suspicion and initial X-ray may be normal. In the later stage, there is sclerosis of the femoral head with flattening and fragmentation. Sclerosis of the femoral head and flattening and fragmentation. It reveals limited internal rotation and abduction of the hip. Limited internal rotation and abduction of the hip. Proximal thigh atrophy and Trendelenburg sign. Proximal thigh atrophy and Trendelenburg sign may be present. Treatment aimed at maintaining the femoral head with the acetabulum by avoiding weight-bearing activity and splinting. Okay, this is a Legg Calve Perthe disease. So, this 7-year-old boy, there is avascular necrosis of the femoral head. Look at the avascular necrosis of the left femoral head. So, you can easily say this is not avascular necrosis. This is the growth plate. In these a 7 years old boy, this is normal, but this is avascular necrosis. So, avascular necrosis of the femoral head looks like Legg Calve Perthe disease. Okay, now if we look at this question in here, this 10 year this 10-year-old girl is brought to the clinic for evaluation of limb. In Legg Calve Perthe disease, the patient again the patient again come to limp, and in this 10-year-old girl come with a limp. First, he noticed mild pain in the right groin 2 weeks ago. Right groin 2 weeks ago. Took ibuprofen. She has been unable to fully bear weight on his right leg. He is unable to fully bear his weight on the right leg due to pain, and which is minimally relieved with ibuprofen. The patient has autoimmune disease, autoimmune hypothyroidism. He is taking, and when the hip is flexed, when the left hip is flexed, the hip remains in a neutral position. When the left hip is placed, the hip remains in a neutral position. But when right hip is flexed, there is external rotation. There is external rotation of the hip. So when the right hip is flexed, there is external rotation of the hip like this pattern. But when the left hip is flexed, the hip remains in the neutral position. This is important. The patient has limp, bears a light weight on their right side when walking. Bilateral hip radiograph, frog leg lateral view shows these. Look at this femoral head, and so it has been slipped. So this is slipped capital femoral epiphysis. In here you need to do physis stabilization with screw fixation. So this is slipped capital femoral epiphysis, posteriorly displaced femoral head, posteriorly displaced femoral head. So this patient has slipped capital femoral epiphysis, which is characterized by displacement of the proximal femur relative to the femoral head due to weakening of the femoral growth plate. So it is most commonly in obese and adolescent because of thyroid hormone promote ossification of the growth plate, because thyroid hormone promote ossification of the growth plate with hypothyroidism, such as in this patient is an increased risk. As thyroid hormone shows ossification of the growth plate, patients with hypothyroidism can have it. Children with endocrinopathies often slip capital femoral epiphysis at an early age, less than 10, are more likely to develop bilateral disease. Slip capital femoral epiphysis with insidious onset of hip, thigh, knee pain, leading to limping, minor trauma, uh, as in this patient can sometimes exacerbate minor trauma, and as in this patient sometimes exacerbate the pain and prompt the and from the patient to seek medical attention. Examination shows limited internal rotation of the hip and the thigh externally rotates during passive flexion. This one is very high yield. When there is when the right hip is flexed, when the right hip is flexed, there is external rotation of the hip. If the left hip is flexed, it remains in the neutral position. If we look at this question again, so how we can diagnose? When he stands with the feet together, the right foot points outward, the left foot remains straight ahead. So this is another clue point for diagnosing slipped capital femoral epiphysis. So he has a groin pain again, groin pain, possibly playing soccer. During stretching exercise, this pain is worst. In the past 4 weeks, he developed a limp and difficulty climbing stairs at home. When the patient stands with feet together, when the patient stands with feet together, the right foot points outward and the left foot remains in the neutral position. When he stands with the right leg, the left half of the leg drops down. When he stands with the left leg, the pelvis remains at the same level. So positive Trendelenburg sign. Do bilateral hip X-ray. So Trendelenburg sign, positive Trendelenburg sign. In positive Trendelenburg sign is also present in Legg Calve Perthe disease, but in here there is hip pain, restricted hip abduction and internal rotation, but in sleep capital femoral epiphysis there is there is not problem in hip abduction and internal rotation. It just when you flexed the hip it causes external rotation like that. So when and it is associated with hypothyroidism or associated with hypothyroidism. And when the right hip is flexed, so there is external rotation of the hip like that. This is a very high yield point for slipped capital femoral epiphysis. And like in here, when he stands with feet together, the right foot points outward. The right foot points outward. This is another. So this is slipped capital femoral epiphysis. Looking at the X-ray, there is slipping of the femoral head. So wide physis, lateral and superior displacement. Wide physis, lateral and superior displacement of the proximal femur line along the proximal line along femoral neck, line along femoral neck, and does not intersect with epiphysis. If we look at this question, family history is sickle cell and the left hip demonstrate decreased range of motion with internal rotation. There is increased warmth. There is increased warmth to the joint. The left foot points laterally during ambulation. So the left foot pointing towards the ambulation. This is another clue point. And he has sickle cell disease. This is another clue. So looks like slip capital femoral epiphysis. So in here there is dull thigh pain hip slipped capital femoral epiphysis in obese adolescent are higher risk. In here there is anterosuperior displacement of proximal femoral diaphysis. Anterosuperior displacement of proximal femoral diaphysis given and the appearance of posterior displaced femoral. So there is dull pain, ache in the hip, thigh, exaggerated by activity, abduction and external rotation of the thigh during passive flexion of the hip, adduction and external rotation of the thigh during passive flexion of the hip is the characteristic. Diagnosis is confirmed by posteriorly slipped capital on femoral X-ray, posteriorly slipped capital on femoral X-ray. Okay, if we look at this question, the patient walks with a limp, right foot is pointed laterally. This is foot if it is pointed laterally. This is central if it is pointed laterally, limp, range of movement and range of motion of the right hip is limited and the knee points laterally upon passive flexion. Passive hip flexion causes knee point laterally. Okay, if we look at this question, both there is limited internal rotation bilaterally, there is mild tenderness in the bilateral anterior region. Sorry, anterior groin, bilateral anterior groin. Both hips and externally rotate during hip flexion. There is palpable both hip externally rotated during hip flexion. There are no palpable clip when the hips are brought together during extension. This patient has waddling gait, muscle soreness. So there is hip flexion, waddling gait, bilateral knee in full range of motion. There is limited internal rotation. There is tenderness on the bilateral anterior groin. So this adolescent girl with limited internal rotation of the hip consistent with slipped capital femoral epiphysis. Weakness of the femoral epiphysis growth plate causes displacement of proximal femoral diaphysis and posterior slippage of the femoral head. Both hips less than 40% of the cases, both hips affected in less than 40% of the cases, unilateral slip capital femoral epiphysis in the contralateral hip in the future. So obesity, adolescent, dull hip pain, referred knee pain, altered gait, limited internal rotation of the hip, posterior displaced femoral head on X-ray, non-weight bearing surgical pinning. Complication is avascular necrosis. And osteoarthritis. Okay, final topic. Final topic is transient synovitis. Again, 8-year-old girl. Again, it comes with limp, but there is no abnormality. When supine, the patient holds the right hip slightly flexed and resisted extension and internal rotation. So they are when supine, they are actually uh, they keep the foot slightly flexed and resisted extension and internal rotation. Mm, Ultrasound show intercapsular fluid. Ultrasound of the hip shows small intercapsular fluid, so looks like transient synovitis. It happens after after viral infection. So it happens after a viral infection or after a trip. So conservative, it fully recovers. Recurrence is uncommon. If you look at this question again, the 5-year-old boy, hip pain, limp, upper respiratory infection, slightly abducted and externally rotated and mildly decreased range of motion. So as they are in pain, so they do not give the opportunity to move the foot. Okay, so ibuprofen and close follow-up. Transient synovitis 3 to 8 preceding viral infection will appear in child, limb, hip pain, normal WBC, ESR, small effusion, ultrasound conservative, NSA, full recovery, recurrence confirmed. Finally, this question has the same pattern too. The patient wails and resists. Everything is normal. It's not septic arteritis because everything is normal. Again, this pain CSR is normal. Leukocyte count is normal. Ultrasound show bilateral effusion. So looks like transient synovitis. So that's all about Legg Calve Perthe disease, slip capital femoral epiphysis and transient synovitis. Hope you enjoy.